Now let us start with 51st chapter of your Apurba Sastry Essentials of Microbiology, which is Staphylococcal infections. In this chapter, we will be covering the Staph aureus infections and the coagulase negative staphylococcal infections. In this video, we will be covering the pathogenesis of Staph aureus infections, while the lab diagnosis and the coagulase negative staph infections will be covered in the subsequent videos. Introduction. Gram-positive cocci are classified into two families, Micrococcaceae and Streptococcaceae, differentiated by catalase test. Micrococcaceae are catalase positive, gram-positive cocci arranged in tetrads or clusters, whereas Streptococcaceae are catalase negative, gram-positive cocci arranged in pair or chains. Family Micrococcaceae comprises of genera Micrococcus and Staphylococcus. Micrococcus species are skin commensals, usually not associated with human infections. They are 1 to 1.8 micrometer in size, arranged in tetrads. Staph Staphylococcus species are arranged in clusters. Staph aureus is the most pathogenic species. It produces an enzyme coagulase which forms the basis of coagulase test, whereas the other species do not produce coagulase and called as coagulase negative staphylococci cons. They are rarely pathogenic to man. Many cause infections in immunocompromised patients. Staph epidermidis is the most common cons infecting man. Others include Staph saprophyticus, Staph lugdonenis, and Staph cellifri, Staph hemolyticus, and Staph warneri. History. Staphylococcus was named after the Greek word staphyli, means a bunch of grapes, and kokos means berry shaped, by Sir Alexander Ogston, 1880, Rosenbach, 1884, named the species Staph aureus based on the characteristic golden yellow pigmentation of its colonies. Staphylococcus aureus infections. Staphylococcus aureus is catalase positive, coagulase positive, facultative, anaerobe, non-motile, non-sporing, and occasionally capsulated. They are spherical cocci about 1 micrometer in diameter, arranged in grape-like clusters. This arrangement is due to the cell division in Staph aureus, which occurs in multiple planes, with daughter cells remain attached together. It produces golden yellow pigmentation on nutrient agar and beta hemolytic colonies on blood agar. Staph aureus is the most virulent species among the staphylococci. Produces infections which range from localized pyogenic infections to life-threatening systemic infections in man. Its importance as human pathogen is greatly enhanced, especially in hospital environment, because of its ability to develop drug resistance. Virulence factors. Staph aureus possess array of virulence factors, which we'll see soon. Now, the cell wall associated factors, like most gram-positive bacteria, the cell wall of Staph aureus consists of a thick peptidoglycan layer and teichoic acid. Staph aureus has additional factors in cell wall such as protein A and clumping factor. Peptidoglycan, similar to the other gram-positive bacteria, the peptidoglycan layer of Staph aureus is thicker. It confers rigidity to the cell wall and maintains the shape. It induces inflammatory response and also has endotoxin-like activity. Teichoic acid is made up of ribitol phosphate polymers, helps in adhesion of cocci to mucosal surfaces and inhibits opsonization. Cell surface adhesins are as follows: clumping factor bound coagulase. It is a fibrinogen binding adhesin responsible for slight coagulase reaction. Fibronectin binding adhesin, collagen binding adhesin. Protein A, SPA, is 42 kilodalton polypeptide encoded by SPA gene. It is present in 90 to 99% of human Staph aureus strains, especially the Cowan I strains. Protein A has many biological properties such as anti-complementary, chemotactic, mitogenic, inhibition of opsonization, and induction of platelet damage. Mediates coagulation, agglutination reaction. Protein A binds to Fc region of any IgG antibody, leaving FAB region free, which binds to the corresponding antigen present in the clinical samples. This test is obsolete now. Microcapsule. Some strains of Staph aureus have polysaccharide microcapsule which inhibits phagocytosis by neutrophils. The capsule polysaccharides are zwitteronic, that is, they have both negative and positive charges, which is a feature that is critical for abscess formation. Now let us see the virulence factor once. The cell wall associated factors which we have read just now: peptidoglycan, teichoic acid, cell surface adhesins, example clumping factor and protein A. The toxins, like membrane active toxins, hemolysins, alpha, beta, gamma, delta, leukocidin or penton valentine toxin, epidermolytic toxin, which is exfoliative toxin, enterotoxin, toxic shock syndrome toxin. Now, extracellular enzymes, coagulase, heat stable thermonuclease, deoxyribonuclease, staphylokinase, fibrinolysin, others like hyaluronidase and lipase and protease. Toxins, membrane active toxins, hemolysins. Staph aureus produce four distinct hemolysins, alpha, beta, gamma, and delta hemolysins. They are membrane damaging toxins, act on red blood cells leading to the hemolysis. They exhibit various actions such as dermonecrotic, cytotoxic, neurotoxic, and leucocidal activities. Leucocidins or Panton valentine toxin. It is also called as Panton valentine PV toxin, named after its discoverers. It acts synergistically with gamma hemolysin to damage leukocytes, RBC, and macrophages. Syner- Synergohymenotropic toxins, alpha hemolysin and PV toxin, are called as synergohymenotropic toxins because they are not active individually but in combination. They are capable of producing hemolytic and leukocidal activity. PV toxin is expressed on MRSA methicillin resistant Staphylococcus aureus strains, which are associated with the community acquired infections. Epidermolytic exfoliative toxin ET. This toxin is responsible for staphylococcal scalded skin syndrome SSSS. Okay. Now, it comprises of two proteins, ETA chromosomal heat stable and ETB plasmid coded heat labile. It often occurs in newborns and children more often than adults. Illness may vary from localized tender blisters and bullae formation to exfoliation and separation of outer epidermal layer, leaving denuded underlying skin. The latter is called Nikolsky sign. Okay. The mucous membranes are usually spread. Severe form in newborn is called as Ritter's syndrome, characterized by fever, lethargy, irritability with poor feeding. Milder forms pemphigus neonatorum and bullous impetigo. And enterotoxin. Enterotoxin is expressed by nearly 50% of Staph aureus strains and is responsible for staphylococcal food poisoning. It is preformed toxin secreted in food before consumption so that it can act rapidly. As a result, the incubation period is short, 1 to 6 hours. Serotyping. Enterotoxins can be typed into 15 serotypes. A to E and G to P all act as superantigens. Type A is most common to cause food poisoning. Serotype F does not cause food poisoning but causes toxic shock syndrome. Now, the toxic shock syndrome toxin TSST. This toxin is responsible for toxic shock syndrome TSS. It has two subtypes TSST1 and TSST2. Both act as superantigens. TSST1 is actually a staphylococcal enterotoxin. Enterotoxin F, formerly called as pyrogenic, and exotoxin C is the most common type of TSST1. Rarely, enterotoxin B or C may be associated. Risk factors. Initially, the toxic shock syndrome was reported from women using highly absorbent vaginal tampons during menstruation. Subsequently, TSS has been reported from both men and non-menstruating women as a complication of staphylococcal abscesses, osteomyelitis, and post-surgical traumatic or burn wound infections. Pathogenesis. TSST1 gets absorbed into circulation from the tampons. Then, being a superantigen, it stimulates the T cells non-specifically by binding to V beta region of the T cell receptor, causing excessive production of cytokine storm, which leads to a potentially fatal multisystem disease. Both TSST and enterotoxin are examples of superantigens described in a further chapter. Clinical features. Patients present with fever, hypotension, mucosal conjunctival hyperemia, vomiting, diarrhea, confusion, myalgia, abdominal pain, and erythematous rashes, which desquamate later. Subsequently, there is rapid involvement of the other organs such as liver, kidney, lung, gastrointestinal tract, or CNS. Case definition of TSS includes clinical criteria: fever, rash, desquamation, hypotension, multi-organ in more than or equal to 3 involvement plus. Lab criteria: negative blood culture for other pathogens and lack of evidence of other causes of infection. Anti-TSST antibodies usually appear in the convalescent stage. They are protective in nature. TSS is more severe if anti-TSST antibodies fail to appear. Diagnosis. Detection of TSST can be done by latex agglutination test and enzyme immunoassay. PCR based assays are available for detection of TSST genes 1 and 2. Other findings may include altered liver kidney function test and low platelet count. Treatment of toxic shock syndrome, as toxin cause rapid capillary leak, aggressive parenteral fluid replacement and vasopressor to reverse hypotension should be initiated at the earliest. Examine for and remove any colonized foreign body, example vaginal tampon. Clindamycin is the preferred drug for TSS as it reduces the toxin synthesis. It is given along with anti-staphylococcal penicillin, example cloaxicillin, for MSSA or vancomycin for MRSA. For clindamycin resistant cases, linezolid can be used for toxin suppression. In such case, addition of vancomycin is not required. Extracellular enzymes. Coagulase. The unique feature of Staph aureus is that it secretes coagulase enzyme, the principal virulence factor in host when it comes in contact with blood brings about clotting or coagulation of blood by activating prothrombin, which in turn converts fibrinogen to fibrin. The fibrin clot surrounding the bacteria may protect it from phagocytosis and other defense mechanisms. This property also serves as the basis of tube coagulase test, the most important test used for identification of Staph aureus. Other enzymes, heat stable thermonuclease and DNase deoxyribonuclease, are the enzymes that are specific to Staph aureus, not produced by any other staphylococcal species. Staphylokinase fibrinolysin breaks down fibrin clots and may facilitate the spread of infection. Hyaluronidase breaks down the connective tissue network. Lipases and phospholipases break down the lipids. Pathogenesis. Pathogenesis of Staph aureus involves the following steps. Colonization. Staph aureus colonizes on various body surfaces such as anterior nares, oropharynx, axilla, and perineal skin. Introduction to the tissue. Organisms are introduced into the tissue as a result of minor abrasions on instrumentation. They adhere to the tissue surfaces, which is mediated by various adhesins. Example: clumping factor and collagen binding adhesion. Invasion. Staph aureus can invade into the tissues by elaborating enzymes such as serine proteases, hyaluronidases, thermonucleases, and lipases. These enzymes facilitate bacterial survival and local spread across tissue surfaces. Examples: lipases help survival in lipid-rich areas like hair follicles. Evasion of host defense mechanisms. Staph aureus exhibits various immune evasion mechanisms such as antiphagocytic activity mediated by microcapsule and protein A, inhibition of leukocytic migration by chemotaxis, inhibitory protein of staphylococci, intracellular survival inside the endothelial cells by formation of small colony variants. Metastatic spread. Finally, Staph aureus spreads to various distant sites by hematogenous spread. Clinical manifestations. Staph aureus is a pluripotent pathogen causing various diseases through both toxin-mediated and non-toxin-mediated mechanisms. It is responsible for both healthcare and community-associated infections that range from relatively minor skin and soft tissue infections to life-threatening systemic infections. Epidemiology. Staphylococcus aureus is a part of normal human flora. About 20 to 40% of healthy population are carriers of Staph aureus, colonizing the organism persistently or transiently. Most common sites of colonization are anterior nares and oropharynx, followed by skin abraded vagina, axilla, and perineum. These colonization sites serve as a reservoir for future infections. The rate of colonization is high among insulin-dependent diabetics, HIV-infected patients undergoing hemodialysis, injection drug users, and individuals with skin damage. Overall, Staph aureus is a leading cause of healthcare associated infections. In hospitals, the healthcare professionals are the potential carriers of Staph aureus. Hospital strains are often multi-drug resistant, spread to patients either from hospital staff or other patients or environment, or also from patients' own endogenous flora. Okay, so now let us come to the clinical spectrum of Staphylococcus aureus infections. Skin and soft tissue infection. Staph aureus is one of the most common cause of various skin and soft tissue infections such as folliculitis, infection of the hair follicle characterized by a pus point surrounded by induration and erythema, furuncle, boil, painful pustular lesion in hairy, moist regions due to infection of the hair follicle that extends to become true abscess. Carbuncle, severe painful lesion at the lower neck region extending to the deeper subcutaneous tissue. Abscesses, collection of pus appears painful and swollen surrounded by erythema. Mastitis and breast abscess in nursing mothers. Impetigo, it mainly occurs in children, usually appears as red sores on the face. that burst and develop into honey-colored crust. Surgical site wound infection, most common cause. Cellulitis, inflammation of skin and subcutaneous tissue, usually develops around a wound or an ulcer. Hidradenitis suppurativa, a recurrent follicular infection in areas rich in apocrine glands such as the axilla. Porteromycosis is a mycetoma-like condition characterized by subcutaneous swelling, sinuses, and discharge containing granules. Note the pustular lesions of Staph aureus infection usually heal quickly when the pus is drained. The fibrinous wall around the abscess tend to prevent the spread of organism and therefore should be taken not to break the fibrinous wall by manipulation or trauma. Okay. Predisposing factors to Staph aureus cutaneous infections are chronic skin conditions, example eczema, skin damage, trauma, injection, or poor personal hygiene. Now, the musculoskeletal infection, Staph aureus is the most common cause of various conditions such as septic arthritis. Most commonly involved joints are knees, shoulder, hips, and phalanges. Osteomyelitis, most commonly affected site in children is strong, long bones, and adults is vertebrae. Pyomyositis, skeletal muscle infection mainly seen in tropical climates but also occurs in HIV infected patients. Abscesses, psoas abscess and epidural abscess. Respiratory tract infection, ventilator associated pneumonia in adults. Septic pulmonary emboli, post-viral pneumonia, example influenza, empyema and pneumothorax, and pneumococcal, shaggy thin walled cavities in lungs. In neonates, Staph aureus is the most common cause. Bacteremia and its complications, sepsis, septic shock, central line associated bloodstream infection, CLABSI, Staph aureus and cons are the leading causative agents. Metastatic foci of infection involving kidney, joints, bone and lung. Infective endocarditis, native valve endocarditis, left-sided, Staph aureus is the most common cause. Prosthetic valve endocarditis, intravenous drug use associated endocarditis, right-sided, Staph aureus is the most common cause. Nosocomial endocarditis associated with increased use of central line. UTI, urinary tract infection, Staphylococcal UTI and pyelonephritis usually occur secondary to bacteremia. Rarely UTI is seen following instrumentation and insertion of catheter or implants. Toxin-mediated illness, Staph aureus causes the following toxin-mediated illnesses: toxic shock syndrome, food poisoning, staphylococcal scale-dead skin syndrome. Infections associated with CA-MRSA, community-associated methicillin-resistant Staphylococcus aureus. Skin and soft tissues are the most common site for colonization of CA-MRSA strains. About 5 to 10% of the strains are invasive and can be life-threatening. Examples include necrotizing pneumonia, sepsis with Waterhouse-Friderichsen syndrome, or purpura fluminescens. Staph aureus is rare cause, most commonly caused by meningococcus. Necrotizing vasculitis, Staph aureus and Streptococcus pyogenes are the common causative agents. Now in this figure we can see the staphylococcal folliculitis and the staphylococcal abscess which is ruptured. Okay, so this completes the pathogenesis. The lab diagnosis and the coagulase negative part we'll be covering in the next video. Like, share, subscribe. Thanks for watching.